Pharynx. The pharynx is divided into three areas. You know, if you just sit down with this slide and be able to understand and identify all of these structures by this weekend, I think, you know, that will be a good thing. Okay. All right. So in this illustration, the nasal septum is in place. Behind the nasal septum back here is the area we call the nasopharynx. And in the area of the pharynx that you could reach through your mouth is called the oropharynx. And in the area of the pharynx down here is called the laryngopharynx.
Can you point to it again?
Yeah, there's the larynx right there. There's your vocal folds. So this area right in here is the laryngopharynx. I don't care that you know those three terms, but it's rather obvious. You know, the pharynx extends from down here all the way up to the base of the skull, essentially. That behind your nose is nasopharynx, oropharynx, laryngopharynx. It does make a big deal if you happen to go to work for an ENT. But primary care, you're not. One of the things, we've talked about different tonsils. We talked about the palatine tonsils and the lingual tonsils. There's also another, a couple of other sets of tonsils up in the nasopharynx, and that's kind of why I gave you those definitions. One of them is the tonsils are associated, I can't reach that high, are associated with the posterior wall of the nasopharynx. Those tonsils are called, well, if they're inflamed, they're called adenoids. They're called adenoids. If you just use that term, anatomically, if they're not inflamed, they have another name, but nobody is ever going to care. Understand that the adenoids are up beyond the soft palate. There's the uvula right there. So the adenoids are up here. Now, you see that little opening right there? The little hole? That's the opening of the eustachian tube. Around the eustachian tube, around that opening, you're going to see this better in another slide. Around that opening, there's another set of tonsils called tubule or tubular tonsils. They're very small, but the reason I point them out to you, or tell you them, is that tonsils are lymphatic tissues, and we talked about early on that you'll find lymphatic tissues wherever you have an opening to the outside world. So you have the palatine tonsils, the lingual tonsils protecting the mouth. You have the adenoids protecting the nasal cavity. You have the tubule tonsils protecting the eustachian tube. The thing about the adenoids, though, is in little kids, they have their tonsils can get huge. And they can be chronically large, as well as the adenoids. When the adenoids swell, it blocks the nasal passageways here, and they wind up being mouth breathers. Little kids, they're so swollen in the back of their nose, and they have a sort of a nasal tone to their voice, and they breathe through their mouth, and when they sleep, they can't breathe through their nose. They're always lying on their back, mouth breathing. Because the swelling will often block the eustachian tube here, they have frequent ear infections. And that's why people, at least back in my day, everybody had a TNA, a tonsillectomy, which means the palatine tonsils, and an adenoidectomy, a TNA. They don't do them quite as much as they used to, But still, if you have a lot of recurrent ear infections, they'll go ahead and do it. Anybody here had a TNA? 1, 2, 3, 4, only 4 of us. So the rest of you have your tonsils? Wow. See, your generation, they really cut down on doing them. My generation, every kid had a TNA. Okay, now, you see that muscle right there? That muscle forms the posterior wall of the pharynx. The posterior wall of the pharynx, those muscles are called constrictors, and they're skeletal muscles. You control them. They're innervated by the cranial nerve 10, and they form a, they go all the way up to the base of the skull, and understand that they originate in the midline in the back. They originate here in the midline and wrap around the pharynx. So they form a tube of flat muscles. So when you swallow, go ahead and swallow. You intentionally swallow, you feel the motor innervation to those pharyngeal constrictors as you swallow. And these things sort of form a funnel all the way up to the base of your skull. But notice how thin they are. They're pretty thin. I mentioned to you, I believe on day one, that infection, if it got through there, it could pass through all the way into the chest cavity in that retropharyngeal space. Here's the opening of the eustachian tube right there, or pharyngotympanic tube, eustachian tube, also called the auditory tube. It has a bump on it like that with a fold. You see that fold right there? That fold has a muscle deep to it that can contract to help close off parts of that tube and also to help elevate the pharynx. The muscle, in case you don't need to know this, but it has such a beautiful name, I want to say it. The word for the tube is salpingo. So because that muscle goes from the tube into your pharynx, that's called the salpingopharyngeus muscle. Beautiful name. Worthless muscle. Okay. We're going to do, I think, the nasal cavity tomorrow, so I'm not going to go into the details here. There's the opening of the auditory tube, its connection to the middle ear. You can see the point I was trying to make yesterday about nasal congestion blocking that tube, and the use of decongestants and nasal steroid sprays to help decrease the thickness of the mucous membrane. Anybody here on a nasal steroid spray?
Sometimes.
No? Yeah, they're over the counter now. They're very effective if you get a lot of rhinitis. In this slide here, it shows important stuff. And if you focus on these things with the little arrows and appreciate them, I think you'll be ahead of the game in being able to define what they are. Okay. Again, you see the opening of the auditory tube. There's the soft palate, the hard palate. The palatine foramina would be over here laterally. There's the valgus papillae, lingual tonsils. This is what it looks like on the inside. Here's the palatoglossal fold, palatopharyngeal fold, palatine tonsils in between. Uvula, soft palate, The hard palate would be anteriorly, obviously. The uvula is innervated, actually has two muscles that go to it. One of them, when it contracts, it pulls the uvula laterally and flattens it. The other one, the other muscle, comes down from above into the uvula from the sides, from above, like this. So the uvula would hang off like this, right? That muscle is called the levator veli, V-E-L-I, palatini. The levator veli palatini. It sounds like something you would get in an Italian restaurant. I suddenly want pasta. Anyway, the only reason I'm going to find this muscle is the reason I'm telling you about it is because clinically it is relevant. It's innervated by cranial nerve 10. So if you're going to test the function of cranial nerve 10, what you do is you look at the uvula and get the patient to say, ah. The levator, as it says, will levate or raise. It raises the uvula in the midline. If one side of cranial nerve 10 doesn't work, let's say this side here, my right side, and you get the patient to say, ah, the left side will work, and it will pull the uvula towards the left, so the uvula will point away from the site of the lesion. That's why you say, ah. You test the function of cranial nerve 10, and you watch for its deviation. It will point away from the site of the lesion. Between the palatoglossal and the palatopharyngeal folds is the tonsillar bed. There are two things about that are important. One is when you remove the palatine tonsils, the artery that can bleed, or the artery that supplies the palatine tonsil is the facial. One of the complications of doing a TNA is excessive bleeding. And that bleeding site is the palatine branch of the facial artery. It's not the maxillary that supplies, the maxillary supplies all of the oral cavity except the tonsillar bed. That's by the facial.
I've seen a few post-op tonsillectomies gone pretty bad, and so that's what, like usually when I've seen the ER, they immediately get to the surgeon. Is that because?
They gotta go stop that bleeding. Because it's such a huge vessel. I mean, it's so close to your heart.
Yeah.
They can really bleed badly. I don't know what the incidence of bleeding with tonsillectomy is. It's probably like 1% or so. But when they go bad, they go bad.
So is that primarily just palatine tonsils, or can it be?
The adenoids don't typically bleed that bad.
So after TNA, is it possible that people have more posterior nosebleeds? Or
No, not related. Nope. Okay. Also, a nerve that is present in the floor of the oral cavity that can be injured during a tonsillectomy is the glossopharyngeal nerve, the ninth cranial nerve. The ninth cranial nerve, remember, provides taste buds to the posterior 1/3 and sensation to the posterior 1/3 of the tongue. You do not want to cut that nerve, but it can be cut incidentally in a tonsillectomy. So it's the ninth cranial nerve that's at risk in tonsillectomy. Here are the pharyngeal constrictors from the back. So So they originate along this thing called a median raphe. Raphe is where it's like an interwoven deal. So there's the median raphe, and they wrap around and join in the front. There's a superior, middle, and an inferior constrictor. The superior constrictor, you see right there, attaches into the back of the mandible into a structure. It's called the pterygomandibular raphe. I don't really care that you know that. If you put your finger in your mouth again, remember the ligament that you felt there? Beside the ligament, there's another ridge that you can feel. That's the raphe right there. So the superior constrictor goes into the back of your mouth. You see, it goes all the way up to the base of the skull, though. It originates all the way up to the base of the skull. The middle constrictor attaches anteriorly, inserts into the hyoid bone. The inferior constrictor inserts into the thyroid cricoid cartridges. They are somatic. The mucosa overlying them, the sensation of the mucosa is by the 9th cranial nerve. The motor aspect of the constrictors is the 10th cranial nerve. I mentioned that earlier. During a physical exam, if you want to test the function of cranial nerves 9 and 10, to test 10, you can get them to say ah. 10 also goes to speech. We know the recurrent laryngeals, right? So if they have normal speech, they probably have normal functioning 10. But another way to test 9 and 10 together is to take a tongue blade and touch the back of the mouth. What happens when you do that? You gag. The sensory limb of that gag reflex is 9. That means you can feel it. The motor gag itself is 10. So the gag reflex will test cranial nerves 9 and 10. Here are some examples of stuff inside the mouth. We talked about diphtheria the other day. There's strep pyogenes creating exudates on the tonsils, palatine tonsils. You see how enlarged they are? Down here is gonococcal pharyngitis, gonorrhea of the mouth. Oklahoma is #1 in the country in the incidence. Did I mention that before? It's #1 in gonococcal pharyngitis. You can't tell them apart really. You can't diphtheria, but you just can't look into a mouth and tell what it is. 90% of sore throats are viral to start with. So there's a thing called a strep test. It tests for the presence of strep pyogenes antigens. So it says here, common signs and symptoms of all three of those: fever, sore throat. The unique features, viral as most of them, tend to have a higher, more rapid fever, rapid going up and down fever. Rare pustules on a viral sore throat, mostly just red and swollen. Cough, you usually don't have cough with strep throat. You can, but it's not typical. It's more associated with viral. Strep, once you smell strep in a throat and you confirm that with a strep test that it is strep, you won't forget that smell. And to me, it smells metallic. I don't know any of the clinicians and people with clinical backgrounds in here. To me, it smells metallic. So, if you don't treat strep throat, there's only a small percentage that will go on to form, to develop rheumatic fever or glomerulonephritis or one of the sequelae of strep throat. But nonetheless, you always, by convention, treat strep throat with antibiotics. It's really malpractice. If you have a viral sore throat, it's really malpractice to treat them with antibiotics. You know, it really is. But most people, unfortunately, expect antibiotics for a sore throat. It's going to be your job to tell them you don't need antibiotics. Okay? If you give them antibiotics for a strep throat, it's really a viral sore throat, which happens 90% of the time, then you got to worry about Taylor's yeast infection, the possibility of pseudomembranous colitis. You know, there are other things you have to worry about. Okay? Or allergy to the antibiotic.
There's a place that I went in college to, like a clinic, and what they would almost always do is they would say, we're pretty sure this is viral, but we're going to give you an antibiotic in case you get a secondary infection.
That is absolutely wrong.
Okay.
That is absolutely wrong. You don't give a person antibiotics unless you know what you're going to treat. Okay. You know, I was thinking about this morning. The gonococcal pharyngitis. And I wasn't thinking about that. I was thinking about, we mentioned the other day, I think, did we mention in here that cervical cancer and HPV, human papillomavirus? Did I mention, or did I just read that? So most cervical cancers now, almost all of them, 99% of them, are related to infection with human papillomavirus. And it's turned out that most squamous cell cancers of the oral cavity are also HPV positive. So that, I mean, you got it with oral sex. I mean, that is a sexually transmitted disease. I mean, it's just really interesting, the science of that, how that's come about. That there is a cause. So that's why, another reason why even little boys should be treated with Gardasil. You know, it's recommended now for boys and girls, the anti-HPV. I was just pondering that, that's all. All right, now we look to the larynx here. This is an odd picture here. What we've done here is we've dissected this from the back. So we've removed the vertebra and everything. We've opened up the esophagus from the back. We're looking at it from back here, right? So that is the uvula. So that's the base, that's the tongue. The oral cavity is going into the plane of the board. Right, you're oriented now? Mm-hmm. There's your epiglottis sticking up, which would be right there. Okay? And there are different areas here that you should appreciate. From the epiglottis, there's a line that comes around there. That's called the aryepiglottic fold. You see this soft part right there, and then there's a more of a nodular part right there. That's the cricoid cartilage. The back of the cricoid cartilage is right there. Start with the hyoid bone as far as its formation of its and support of the larynx. The hyoid bone has two prominences, a lesser and greater horn of the hyoid bone, and in the body is what you feel in the front. The hyoid bone is sitting above this, there it is up there. There's a membrane that connects the hyoid bone to the thyroid cartilage. We've already mentioned it. That's the thyrohyoid membrane. Here's the thyroid cartilage from the back. We're viewing it from the back. It's like if It's like this. You take it and you stick it right there. It's opened in the back. The cricoid cartilage is right here is large in the back, small in the front like a high school ring, the signet ring. The thyroid cartilage articulates with the cricoid cartilage right there, these little horns. Sitting on top of the back of the cricoid cartilage are these two cartilages called the arytenoids. On top of the little arytenoids are the corniculate cartilages. You can forget those. Focus on the arytenoids, the cricoid, and the thyroid cartilages. The arytenoid, so here it is in cross section. Here's the signet ring, that's the cricoid. There's the thyroid cartilage, we cut it in half, mid-sagittal section. The arytenoids are shaped like little pyramids, three-sided pyramids. So the point of the pyramid, if that's the point of the pyramid, there's a ligament that comes off the point of the pyramid, of the arytenoid, and attaches to the back of the thyroid cartilage. That's this right here, the ligament. That ligament is called the vocal ligament. If you look at the epiglottis, it's a ridiculous looking structure that attaches, this point attaches or inserts into the thyroid cartilage. It's one of the few places where you have elastic cartilage. The epiglottis and the pinna is elastic cartilage. Here's the thyroid cartilage. We know about the different parts, the thyroid notch, the prominence here, your Adam's apple. The inferior horn is what articulates with the what? Cricoid. Here are the little arytenoids. The points have different processes. Have different names. The one that gives rise to the vocal ligament is called the vocal process. The ones in the back are called muscular processes that you'll see in a minute why that's called that. The cricoid is here. It's the only one that's a true ring. It's the only cartilage in the entire respiratory system that is a true solid ring. All of your tracheal rings are not rings. They're actually horseshoe-shaped structures. This is the only one that's a true ring. You put them together and this is what you got. There's a thyroid membrane, a hypothyroid membrane that seals off these things. Okay? It puts a mucosa on them, and this is what you get now. From the sagittal section here, we've got the vocal ligament underneath that. That's the vocal fold. That's your vocal cord right there. There's actually a muscle over top of that, or between the ligament and the mucosa, called the vocalis muscle. Not that you need to know that, but understand that is the vocal fold. There's a little cave right above it here, and there's another fold on top. The top fold is called the false vocal cord. The true vocal cord is the one on the bottom. That little pit is called the ventricle. Above the false vocal cord, this area here is called the vestibule, and below the fold down here is called the infraglottic area. And then starts your trachea. This is dissecting it from the back. So you have the epiglottis up there, false vocal fold, infraglottic area, beginning of the trachea. You follow that? It's pretty simple. And this is where you put the mucosa on that earlier picture. Epiglottis, arytenoids are in there, there's the cricoid. This would be right here and right there, the thyroid cartilage of the front. Make sense? This little area outside the larynx, right there, is called the piriform recess. Piriform recess. This is where chicken bones, Skittles, and everything else gets stuck. The piriform recess. It's outside the larynx. One other area I forgot to mention on a previous slide is there's the tongue and there's the epiglottis. They're sort of like this. If this is the tongue and there's the epiglottis sticking up, that space right there is called the vallecula. The vallecula. There's the tongue, there's the epiglottis. So the vallecula in this diagram here would be on the other side of the epiglottis right there, right? Two reasons why I point that out to you. One is that chicken bones and Skittles can get stuck there as well. The other reason is when you do an intubation, when you stick a laryngoscope with its blade into the oral cavity to put a tube, a breathing tube in, there are two types of blades. There's a straight blade and a curved blade. When you put a straight blade in there, you put it right here. You lift up the epiglottis. You put a straight blade all the way into the opening of the larynx, and you put, so the epiglottis is underneath the blade. A curved blade, you put it in the vallecula. You put it between the tongue and the epiglottis. So don't forget that. Curved blade goes into the vallecula. Straight blade picks up the epiglottis. There are a whole bunch of what are called extrinsic muscles of the larynx. I mentioned them the other day collectively, is that they contract and relax. They're going to stretch or compress the larynx, thus altering your voice. You know where all these muscles are, you've seen them all. But understand that they have an action on the larynx. Remember I said the other day about these things either have an action on the neck, the larynx, or something else. Oral cavity. There you go. I just made that up when I said that day, but I realized, hey, that's right. You gotta watch out for stuff I say. Sometimes I just make up crap. My wife claims most of it's not true. So. Now, underneath the mucosa, here's the cricoid, there are the arytenoids, there are the epiglottic fold. Underneath the mucosa, there are muscles. And you have a whole bunch of muscles that act on the vocal folds. Those are the extrinsic muscles. These are the intrinsic muscles of the larynx. They're all innervated by what nerve? The what?
Glossopharyngeal.
No.
Vagus?
The vagus. Specifically, what branch of the vagus? Recurrent laryngeal. Right? Recurrent laryngeal. This is the only thing you need to know about all these muscles. You don't need to know the names except for one. All of these muscles act to close the vocal folds, to bring them closer together. And they act by, the arytenoids are right here. They act by, if you take those little pyramids like that, and so the vocal folds come off the end, right? They act by rotating the arytenoids. So if they rotate them medially, they're going to close they're gonna bring them closer together, right? They all act to bring them closer together except one, and that is the posterior cricoarytenoid, which is that muscle right there. That is the only muscle that opens or abducts the vocal folds. The posterior cricoarytenoid. All of the others close it. Here's the recurrent laryngeal right here. The recurrent laryngeal nerve comes up from the bottom to innervate those muscles. Here's a illustration of it, and so that goes over what I just said. But the one thing I want to add to this is that the opening of through the vocal folds is called the rima glottis. When you intubate somebody, you're going to put your endotracheal tube through the rima. And when you intubate somebody, you look for the vocal folds. When they're lying on their back, the vocal folds attach, they come from the two arytenoids, and they attach at the thyroid. So it's going to look like an upside down V. When you get in there with your laryngoscope, what you're looking for is an upside down V. And you're going to put that endotracheal tube right between them through the rima. This is just the action. That's the action of the posterior cricoarytenoids. That's the action of the other arytenoids. They close them. The nerve and blood supply to the larynx. The nerve supply we know, recurrent laryngeal. The arterial supply is off the superior laryngeal, which is a branch of the inferior thyroid. Here's the superior thyroid. There's a superior thyroid coming down. It's going to give off a branch called the superior laryngeal artery. So the larynx is supplied by the external carotid. The venous drainage. Actually, let's not worry about the venous drainage. And finally, we go all the way through the neck. Peel everything off the neck. You're going to get to some muscles that sit in front of the vertebra and have an action on the cervical vertebra. Those things are called the prevertebral muscles. There's longus capitis that attaches to the skull, and longus coli, longus capitis, longus coli that attach to the cervical vertebra. They run vertebra to vertebra. Their role, obviously, is extension of the cervical spine and helping to hold your head up. I'll see you guys at 1. You guys decide when you want to do that review. Okay?
Yeah, we don't have to leave and then we can just study until whenever it is. Probably not to eat. No.
Guys, review session. When's guys review session?
I think, well, Sunday, I feel like Sunday, because you could study all weekend and then ask all your questions.
Or Sunday is fine.
Maybe not.
Can we do it like Sunday afternoon or evening? Because I'm like not morning.
Yeah, I think Sunday night would be good.
Sunday at 6 o'clock. 6 o'clock or 7
Sunday
o'clock.
at 6?
Sunday at 6 or 7, which one?
6.
6.
Sunday at 6.
Sunday at 6.
Does that work for you?
Alright.
You take that? No, what?
Hey, is it Sunday at 6 or Sunday at 7?
6.
6.
We can just do that camera thing.
Hmm.